Just record.
Hi, Victoria.
Hi, Bill. How are you? Sorry for that. I I did have my speakers off and I was trying to muck around with my monitor that just doesn't want to cooperate. So just trying to move everyone off my page. So I can see my slides. Okay. Alrighty. How are you, Dawn?
How are you, Vicky?
Yeah, good, thank you. Oh, look at that lovely garden. Delightful.
That's actually late winter, early spring, complete with cat.
Ah, very nice. Very nice. So Dawn, will you be leading the way of getting us started, or am I to start?
Yeah.
So,
I'll do the introductions. in
Perfect.
another minute or two.
Yep, no worries. We'll stay posted. I might give my monitor one more go then. I'll just turn my, put my mute on.
Hi, Vicky.
How are you, Constantia?
Good, thank you.
Nice to see a friendly face. All the other faces are friendly, but one that I know as well.
Good morning, Chorus Ness here. Thanks, Pudding. Learn something.
Vicky, are you happy to start?
Yeah, would have liked my other monitor to start, but so I don't think it's going to go for it. No, that's all right. So what will happen, Dawn, is just that I won't really be able to see, because I can't get my other monitor to work, I won't really be able to see if people are putting up their hands and all that sort of thing along the way.
Yeah.
So I'm sure you'll give us a bit of a format about how we might operate. But what was I going to say? I've suggested people keep track of their questions in the chat, and also, yeah, I won't see who's joining and whatnot. So
Yeah, we can keep questions and answers for the end, so that way it might be easier to manage.
And typically, I mean, I suspect I could go through these as quickly or as slowly as you like, but I suspect me speaking and then people having a chance to ask questions is the most helpful. That Yep, 30 minutes, all good.
Yeah,
30 minutes.
sounds good.
Great. Sounds good to me. Kick us off. Let's get going.
All right. Well, thank you everyone for joining us today. We have quite a crowd. So today's seminar is hosted by the Centre for Digital Transformation of Health and co-hosted by the Department of General Practice at the University of Melbourne. This event is also endorsed by Volunteer CPD Point. So I'd like to introduce our speaker, Dr. Associate Professor Victoria Palmer. Victoria is trained in applied ethics and participatory methods and has expertise in mixed method design and analysis. She's currently leading the Integrated Mental Health Research Unit, focused on physical mental health integration in primary care and the delivery of person-centered systems and models of care. Victoria also established and leads the Co-Design Living Labs program at the University of Melbourne. The Co-Design Living Labs is a research registry of over 600 people with complex physical and mental.
Thank you very much, Dawn, and welcome everyone. Thanks for coming and having a listen to this presentation today. I very much I'm grateful to have everyone here, and I very much would like to have a conversation about your thoughts and ideas, and ensure that I've answered all of your potential interests by the end of the presentation. So I'll aim to talk for that 20 to 30 minute mark, and then come back and see. As I indicated, people can please use the chat function to make a note of question. If you've got interesting comments, things to expand on, so on and so forth, we can keep track of that through that function there. So I'm an associate professor in the Department of General Practice at the University of Melbourne and the Melbourne Medical School. As Dawn indicated, I lead an integrated mental health research program, and I'll say a little bit more about that. My role with the centre is around the co-design digital health nexus and setting up some ways in which we can embed participation and look at community and patient participation models, including alongside professionals, industry, government, so on and so forth. And I'll come to tell you a bit more about how we got to all of that as we go through the talk. So thank you again for joining. This conversation is also very much about building a science of participation. And again, I will explain more about how we've come to that. But it is also important to acknowledge country and acknowledge the traditional owners of the lands on which this presentation is being given, and also where it's reaching other people today through all of the digital technology, and to acknowledge any elders past, present and emerging in our presentation. I'd also like to recognise there may be members in the room who have lived experience of health conditions and mental health, and that their roles and contributions are also equally acknowledged and important. So a bit about me, and really I was sort of reflecting that this presentation to some degree is the story of the journey from my PhD to now where I am. And I've popped a quote up there that says, many visitors come here and ask us why we have such an unusual business. But I say to them, don't you think it's strange that more organisations in the world are not like this one? And this quote comes from an interview with a worker member in the Mondragon cooperative social system in Basque region of Spain. And some of you may be familiar with this model, others may not. It's a very famous cooperative social system. And Mondragon was the topic of my PhD thesis. So I've had a long-standing interest in cooperatives and cooperative practices over time, and so nearly 20 years now when I think back. But this quote, I was looking at it the other day and I thought, this kind of reflects a little bit where we've landed with the co-design living labs model, in that lots of people come to me and say, can we come and see the living lab, or can we come and talk about what this living lab is? And many people might think it's unusual, but really for us it's about core business, and we wonder why a lot of organisations aren't like this and embedding these models. So that's part of the backdrop to this story. So from my PhD I looked at the role of cooperatives and the role of cooperation in building ethical and moral communities, and have been very interested in all these cooperative practices, and therefore undertaken participatory design research for quite a long time. So as I said, I lead a program in the Department of General Practice. We have 4 key areas of work: patient experience and lived experience of navigating the system, systems redesign and co-design, innovations in care and treatment, and looking at ways to risk stratify, so organising people into mental health needs groups. You can see along the side there that we've got a range of studies that we've been undertaking for a long time in these areas. We have about 15 years of evidence and research experience, and the ACT Healthy Hearts study is my most recent work, looking to reduce cardiovascular risk for and with people with severe mental illness, and working across the primary care setting. And ACT is important just to flag here because it's an extension on from the core study that I'm going to go on to talk with you about, leading up to these co-designed living labs models. And ACT is testing whether a co-produced intervention, one that's where people with lived experience have had very direct input into the design and the testing out of the intervention, and looking at whether when we add co-production into the mix as well, which should be our usual standard way of doing business anyway, whether or not that helps to also make a difference in a very important problem. So it won't be a surprise for many people that people do have a life expectancy that is far less when you have a severe mental illness than people who don't, and a lot of it is linked to cardiovascular risk. So I'm going to give a bit of a backdrop to this participatory zeitgeist that I've been going on about a bit of late, and thinking about the embedding co-design living labs models in the context of this. So I'll talk a bit about that. I'll talk a bit about the co-design project that led to the living labs. I'll share a bit about our living labs model, and then I'll end on how this sort of coalesces and comes together as an idea for building a science of participation. To start with, I just think it's helpful to frame up what I mean by a science and a science of participation. And again, no surprises to anyone else listening here today. A science refers to the systematic study, organisation and synthesis of knowledge of a phenomenon, and importantly, the mobilisation of theories, concepts and methods to better understand the what, why and how that phenomenon works. Now, this is important just to flag early, because I do think that we're looking at in the current healthcare improvement era a phenomenon of participation, and we've always had it to varying degrees, but I think currently there are such a variety of ways in which people are participating, and we're obviously seeing shifts in how that's being conceptualised in the current context of COVID-19. But it's very central to healthcare. It's very central to healthcare policy improvement, and something that we need to understand and look closely at. So before I go into the zeitgeist, I'm just going to draw an analogy here with Da Vinci, who liked to talk about the art and science, and the science and art of mechanics and motion. And I think one of the things that has helped me to think about a science of participation has been to think about Da Vinci's call and his life work in looking at a science of mechanics, and his view that this was a necessary foundation for the study of anatomy and movement. And to some degree, he was talking about how motion has both emotion internally and externally, and how the body moves and interfaces. And I'll go on to say a little bit more about how this comes to be in the context of the science of participation that I'm speaking about also. But what I'm trying to come at is that we need a science of participation as a necessary foundation for the study of how people are engaging and participating and taking part in healthcare and quality improvement. Now here, this is a busy slide. It's not for you to read every particular part of that content, and there won't be a quiz on it later, so don't worry. It's really just to highlight in the space that I work in particular, in the mental health context, this notion of participation as a phenomenon. So, you know, a lot of people will say, well, why should we look at co-design and co-production and think about a science? Well, since reforms have begun in mental health in the Australian context and internationally, we have seen a huge shift and proliferation of reference to participation, and particularly participation of people with lived experience in design, development and evaluation of services. And most recently, which is sort of even not all that recent now, but you know, the UN report that was released in 2017 was talking about the highest attainable standards of physical and mental health for people. And in that report, there was reference to the importance of co-production as a way of achieving that. And we've seen this carried through from particularly here around 2014, where we really started to see in the orange boxes and the orange lines that key policy documents are really drawing on and talking about the importance of co-design and co-production. And really, this has coincided with engagement being posited as the Holy Grail. This is a quote from 2013 from Carmen et al. In Health Affairs, talking about engagement as a necessary condition for the redesign of healthcare and healthcare systems, the Holy Grail of healthcare, and almost the next big blockbuster drug of the century. And if you've been keeping track of this space and you're interested in co-design and participation and co-production, you will have seen this proliferation occurring also. There's no doubt that people have been moving away from a view that patients are passive recipients to healthcare to being active partners in the process, and also a shift towards seeing that involvement and engagement as essential to quality and safety and achieving better healthcare and better healthcare outcomes for people. So that is part of the backdrop to why myself and some colleagues put together some work talking about this participatory zeitgeist. And really we're talking about a confluence of social, political and cultural forces that are particularly apparent in the healthcare design space and delivery and improvement spaces, almost to the extent that it's become the spirit of our times, the spirit of the age and the mood of the times. And I was saying just before about the proliferation and the emphasis on engagement and the emphasis on co-design and co-production. And again, more recently, another document highlighted co-production is a way to achieve positive outcomes for people and communities. So surely we should be measuring those outcomes rather than the co-productive processes that achieve the outcomes. So what we've seen over time is an emphasis on people becoming involved in co-design and becoming involved in improvement processes, but also now a huge shift in the field as well to start taking account of that and to start talking about how those activities and processes should be measured. And I think it was in 2019, Nature, by which everyone regards as a very high quality scientific journal, had a special issue dedicated to co-production. So there's no doubt that we're talking about a phenomenon that I suggest requires some study and further science. So also want to just give you a bit of insight then into the Living Labs model and how that came to be by talking about and sharing a little bit about the core study that led up to it. That was funded under the Victorian State Government Mental Illness Research Fund. It was a one-off $10 million fund that funded 5 projects across Victoria, and we were one of those projects. And we also had some support from the Psychiatric Illness and Intellectual Disability Donations Trust Fund. And you can see there were a large group of people involved in this project, and that is the people in Australia, but we also had colleagues across the globe who participated in our advisory group and our expert advisory and monitoring groups. So really in the core study, when you go back to that slide that I put up that I'm going to ask a quiz on later for everyone about the policy transitions, in the core study we were taking up the challenge. We were funded in 2013, right when these concepts of co-design were becoming very, very popular. We were funded to look at whether a mental health experience co-design intervention could optimise psychosocial recovery outcomes for people living with severe mental illness. And this is a challenge and a challenging hypothesis to test. So we were the first trial in the world of the mental health experience co-design method, and that method was established by the Victorian Mental Illness Awareness Council and Tandem, representing mental health carers, in conjunction with the Department of Health and Human Services at the Victorian Government. And they worked in partnership with us alongside mental health community support services, so looking at non-clinical services and looking specifically at psychosocial recovery. So we designed the study using a step wedge cluster randomised control trial design, and I'll tell you a bit about that very, very briefly. And in many ways, I've come to think about this as a trial that was testing a policy assumption that by involving people with lived experience in service design and service improvement, we may see an increase or an improvement in psychosocial recovery outcomes. And a lot of people might take that to task. However, when you go back to the earlier slide and the earlier points that I've been making, there is an undoubted assumption that involving people does something. And there's also undoubtedly calls to really understand what that something is and to be able to document that and measure that systematically. So this is Wayne and Rosemary, who were our lived experience co-investigators, and they delivered, I cannot even remember now, we were across Victoria, so many focus groups and so many co-design sessions for the trial. The circles there just really highlight the number of different stages and iterations that are involved in co-design, taking people through identifying and having a voice and talking about what are the good experiences, what could improve, agreeing on areas for change, co-developing a number of improvement objectives, working in groups together to co-design improvements for those objectives, and then implementing those improvements. And just before I mentioned, this was a stepped wedge cluster randomised control trial design, and that means that people came on in waves of 3 over the 4 years of the trial. So this is a very long-standing trial also to take note of. In the end, we had about 287 people with lived experience of mental illness who contributed data to at least one time point. 61% were female. People also reported high numbers of having a physical health condition, which was partly what led on to inform our current trial that I mentioned in the beginning, a state of cardiac care. We also had a number of carers, and they were also female. We had 137 staff across Victoria in those services answer some surveys about recovery orientation, and about half of our service users suggested that they had a carer, which is pretty consistent with all of the literature on people who live with mental illness in the community. For the most part, most people had had their mental health conditions for at least 18 years or more. Many of our population were born in Australia, and 1 in 3 carers suggested that they were. Most of the staff have been in services for 6 years or so who took part. I just want to give you a sense that, you know, one of the reasons why we really wanted to understand what was happening for people was about our participants such as Amanda. So Amanda was 46 when she joined the study, born in Australia, diagnosed with bipolar, suggested that she had a friend and a carer that she lived with, had 4 important support people, numbers of physical health problems, hospitalised 4 times, and accessed the mental health community support services to cope with her everyday life and stuff. And at the end, there is a timeline that we asked people to complete at home. And in the comfort, you know, people took time. Some people took 12 months to complete these and send them back. And that was Amanda's depiction of times when she was feeling good and times when she was feeling bad. Typical week, flat, no energy. Someone took her out, forced her to socialise, exhausted, very low feelings, a bit restless on the next day, same as Monday, and suggested by Wednesday creating lists for everything and anything. Now, the reason that I have shared Amanda is just to give you a flavour of the 287 people who participated in the study and the importance of thinking about the different ways of engaging that group of people in co-design and the kinds of challenges that people may be coming with as they come to work in the co-design space. And I'll come and touch back on this a little bit more towards the end of the conversation. But in the end, I think what the key thing to take away from the course study is this reinforcement of the participation paradox. And what we see is when we try to measure the effect of co-design, it's very difficult to see change on outcomes and to know which ones to measure and to determine what's best. But for the participant, when Amanda was asked, what do you think was the most significant change for you? Her suggestion was having a voice, attending the meetings. For me, that was a really big step in my own actual recovery. So for me, it was also good for my recovery goals. I suffer a fair bit from agoraphobia, no confidence. So to have the confidence to be able to speak up, talk, use my intelligence that I don't quite often get to do, just having a voice and being able to say, hey, this doesn't work, and someone actually listened to us. So you can see that what we're highlighting here is that those subjective experiences still very much touched on people's psychosocial recovery outcomes and suggest that something is happening, something is effective, even though the study primary outcomes might not show a full difference. So that did lead us to start to think about what is the anatomy of co-design and co-production? What are we talking about here? And we came up with a model, an explanatory theoretical model of change, myself and some colleagues, which was published last year. And we really wanted to highlight in this model the mechanisms. So we'd had a lot of discussion when we were using mental health experience co-design in the trial, for example, about what we thought was going into everything. And we'd had a really good think about what outcomes we thought we might see. But really, where we felt there was gaps and where we feel that there's still gaps in the field is around the mechanisms of action. What are the things, what are the ingredients, what are the elements that underpin co-design and co-production? And if we can identify these and think about whether we can see these in action and or create the conditions by which these mechanisms can flourish, perhaps we might see more effect and more outcome in the work that we're undertaking. So that work has very much informed the establishment of the co-design living labs model within the integrated mental health program, and for what we've been scaling up beyond that. And so what we had at the end of the course study was a group of people. Not all 287 people took part in co-design themselves, but a substantive proportion had taken part and been trained in co-design. And at the same time, we also had a 10-year longitudinal cohort study completing that was led by Professor Jane Gunn. So we were faced with this problem, or an opportunity, so to speak, whereby all of these participants had contributed either 10 years of data to us and been involved in our research studies for over 10 years, alongside the core participants who'd been involved for over 4 years, alongside being a group of people who generally had reported to us finding it difficult to be heard in the system, difficult to engage in processes, and who'd given us a lot of their time. So it prompted, particularly for me, a moment of thinking about, well, what are some of the opportunities and ways in which research programs, in particular, can ensure that we continue to engage people beyond the life of a study, and to also then use their skills and expertise that we find develop over the course of being involved in research studies in future programs of work. So the co-design living labs model appealed for one. As you know, when you go back to that beginning quote that I put up, I'd studied cooperatives, I'd looked at the cooperative social systems within my PhD thesis. I liked the idea of the living labs model in terms of being open innovation models that bring together industry and government and community to co-design products. So what we set up was a process by which people who complete our research studies and our trials now are then invited into the living labs. And you can see in the middle here, we have a collaborator hub. We try and embed this approach across all of the research continuum. So this represents a cycle, but this might be at the beginning of the design phases. Ideation and design might refer both to a grant and or a product. We bring people back in for intervention development and testing, keep undertaking that prototyping and solutions. We've also had members of our co-design living labs trained to be co-researchers on a number of different studies and to be involved in that sharing and translation. So the research registry now has over 1,000 people, and Constantia's on the line. She's our data manager extraordinaire. But one of the reasons that we wanted to develop a research registry that had scale and vast numbers across the state was to be able to identify people with different age groups, different backgrounds, to keep track of who is taking part in different co-design activities, to then be able to say, oh, well, this person's come along for 5 or 10 sessions and that's great. And they're really having voice and building lots of capabilities, but let's target perhaps the other group of 20 who we haven't heard from for a long period of time. So we typically undertake co-design activities face-to-face, not at the moment, and virtually using other tools and techniques. So people, as I said, are invited to this research registry on completion of the study, and we have a Living Labs coordinator who facilitates that process. And I can't emphasise enough the importance of having that single point of contact, that people really start to feel confident and to feel like they are supported in the process when they have a person who's dedicated to contacting them and inviting them in and supporting them through arriving to a place and space and finding the room and all of those things. Just to give you a flavour, so this was one of our original living labs that we ran, looking at the Healthy Heart Conversation Aid for the Assertive Cardiac Care Trial. Giving you a sense here, we had a number of iterations and cycles. In the beginning, this was my vision over here, and then this is what we ended up with over here that sort of appears like a checklist, very structured, organised format. But this was what, after we went through a number of different cycles and iterations of how might we talk about cardiovascular risk with people, this was in the end the preferred model and the way that people came up with the conversation aid. In those labs, we also talked about recruitment barriers. We used those to develop recruitment strategies. We talked about the messaging of information about heart health, and this again was the tool that we wanted to develop to facilitate conversation about areas of risk. So here's a bit of a flavour of what people said. So attending a co-design lab gave me an insight into what goes on. It's interesting to hear people who come from similar but different walks of life. In the lab, everyone was given fair and equal time, and the people running it didn't favour opinions. I was very impressed with that, and if you're prepared to get up and have a go and go into a lab, you do lose that sense of isolation. Another person suggested that I know I was anxious about getting there on time, and that was all part and parcel of my issues. There was nothing there that made my anxiety worse. There was nothing there that I would be able to say if this was this way, it would have made my anxiety better. So the reason I highlighted that feedback is just again to remind ourselves of Amanda, for example, that I touched on, who is in the core study, and our participants, and the importance of setting up systematic and supportive approaches in our co-design living labs and models. So I've been fortunate to work with the Agency for Clinical Innovation for a number of years now also, and we've very much found in a case study synthesis of 6 of their projects and in the work in the core study that we undertook and the continuing work in the living labs, that there is an assumption that people come with a set of capabilities, so to speak, that enable them to undertake this work. So what we've been working on and highlighting also is the importance of building people's capabilities to undertake co-design work as well. So we mustn't just assume that we can just invite people in and do the co-design and get an outcome very easily and straightforward. Which has led on to bringing together all of these different strands to start to think about developing, as I said in the beginning, a science of participation. And that is so that we can explore these phenomena, bring together well and truly already existing work that's very good in the field. We're not suggesting that there aren't existing models, that there aren't existing theories. There's certainly a lot of work being done across participatory medicine, participatory science, all of the different strands. But we are at a space of an opportunity to think about a science of participation. And importantly for me, that science needs to honour lived experience and take that forward as truly recognising those experiences as an equal form of knowledge and to take that forward into the future. So I think I will pause there. Dawn, where I'm trying to get my Zoom people back up. I'm going to stop sharing unless I need to come back to this.
Thank you, Vicky. Thanks for talking to us about co-design and showing us examples of participatory design and co-production in your work. I'm just having a look at the chat window now, and we've had a few comments. So Sophia says that they'll offer a link to the Nature's special issue, if you have that handy.
Yes. I can type at the same time to call it back up. No problem.
Does anyone have any questions for Vicky? You can either type it or unmute and just...
Got a bit of time. I wanted to allow time in case people want me to unpack different parts. Or we can all go and have lunch.
Sorry, hi, it's Tess Hall. I put a question in the chat, but I don't know if you can see it. Thank you for an awesome talk. I'd just like to hear a little bit more about the co-design processes or the facilitation methods that you used in the labs.
Sure, Tess. So we use traditional co-design methodologies using storyboarding, experience mapping, all of the ones that you'll see out there. There are some great toolkits that already exist and are available, and in particular I've been drawing on the Agency for Clinical Innovations work because we have, I guess, two commitments in our Living Labs model. One is the commitment to experience, and then drawing on methods that will facilitate an experience-based co-design approach to ultimately design healthcare systems that take account of both experience and the importance of protocol and outcome. So very typical, standard personas, all of the above. But our general approach is always to have co-design methods at the fore. So we would rather use those tools that are specifically coming out of the field to facilitate the approach, and also advance on them where we can. So yeah, very standard. And that's why we kept the commitment to having co-design Living Labs in the title, because we wanted to flag that when we undertake these labs, we will have a commitment to using co-design methods for that and approaches.
Okay, we have another question from Karen. How does participatory Living Labs design for shared decision making in GP? And what are not appropriate use of digital tech in your experience?
So I think with the digital tech, it's still an emerging space for us, but where it has been appropriate in particular, I'm going to that question first. Where it has been appropriate has been when we've been at that early ideation stage of research studies and suggesting, well, perhaps it might be important to encourage people to participate in cancer screening, for example, for breast cancer and colorectal cancer. And we've got ideas underway about that. What we've been able to do is send out a number of questions to our Living Labs registry and have quick and easy feedback from people about their ideas and their views at a very, very early stage. And I think that's a very appropriate use and a very appropriate way of keeping a conversation underway with people that we often wouldn't normally be having. We're waiting to undertake a number of interviews, you know, analyse them. So that kind of level of engagement has been good. I think we're still yet to see the full extent of digital engagement now that we've been put into a space where we will need to be undertaking co-design online in the next few months, and how well we can achieve that with tools like Mural, so on and so forth. The key thing, I think, is that it's appropriate to use them, but we're going to have to work with people and have our Living Labs coordinator, for example, have a phase where they're phoning people ahead, ensuring they've got the technology set up and giving people an orientation before we jump into it as well. So we can't just presume that people are going to just have a link, get on and undertake the activities in a straightforward way. With the shared decision making, I suppose there's always a variety of perspectives on shared decision making, and supported decision making has been another model that's been put forward as well. I don't think, if you could go back, Dawn, to that question, because I think it's flowing down a little bit.
Yep. So the question is, how does participatory Living Labs design fit in decision making in general practice?
Yeah, well, I think there's a direct fit. Having a shared and collaborative approach is there in the mix. So it needs to be a shared decision-making approach. It needs to be an approach that's honouring the lived experience perspective and power dynamics. And I guess in some recent work with colleagues in the UK, we've been looking at, you know, that importance of knowing the power dynamics and addressing those in the room as well. So I might just leave that
Okay.
one there.
So the next question is, can you take us through what an average session looks like? For example, how long does it go for? What activities do you use? How much preparations do the participants have done?
So quite a few participants might have had preparation in the sense that they might have been to prior labs, so they know what to expect. There's that side of things. And if I just return back to the paper that I put up on Anyone Can Co-Design, in that particular paper we had started to talk about a need in our work to be a little bit more explicit about the problem at hand that we're trying to tackle and co-design for and with people, and the kind of method that we use. So we very much try to tailor the method that we select to the problem at hand. So it's never a one-size-fits-all approach. If we're looking at overcoming barriers, we might then put together a persona, for example, of all the barriers to give people a starting point. These are some of the known barriers. These are some of the barriers that we've talked about before. And then we will undertake individual persona development to create a collective persona to take the work forward, for example. So those tools are always very much fit for purpose as well. They're selected by the facilitators prior, and we would always spend at least, you know, half an hour of our first session going through, you know, what we're trying to achieve, what are the important working agreements for people. So we have a statement of participation that we run through. The statement of participation has been built on and developed from the mechanisms of action. And so we've fleshed that out. We always ask people to read that and review it, and to also add in any further statements and agreements and things that are important to them in that particular session as well. So things like safety might come up for people, privacy, confidentiality, even though they're mentioned within and across our principles, we have a conversation about those as well. going forward.
All right, so the next question for Vicky is, how do you involve people with lived experience in writing systematic reviews appropriately?
That's a bit of a tough one. Who's asked that?
Annette, oh no,
I think,
Elise, yeah.
no. I think, look, there's so many different
Just
ways.
quickly say hello.
There's so many different ways of engaging people, and when you're coming to systematic review side of things, I guess for me, I just would return back to the research continuum, and this is my perspective, that when we start to engage people in reviews and other activities, we might be starting to move into the co-researcher role. We should start to think about whether we're moving on then from a co-design space. Sure, the co-design living labs participants might have been invited and recruited to that process through that research registry and model that exists. But when people start to contribute and contribute intellectually to a systematic review, for example, they're generally becoming a co-researcher from my perspective, and they need to be somewhat trained in being a co-researcher and supported through that process, and generally employed as a co-researcher as well. So I think there's some fundamental basics and things that have to be in place. And then it's about the training for doing a systematic review and how you might do that. So different teams, particularly a team that I work with, Lisa Brophy, we've been looking at where we might undertake an analysis and a review of data, but then have our lived experience co-researchers look at that data and then prepare and present specific lived experience perspectives, so that people are not necessarily having to do all of the analytic work, but they're able to look at the work and able to contribute a particular perspective to that to advance it and take it forward.
Thank you very much.
All right, so the next question is from Annette, who says, sorry if I missed this, is my connection was cutting in and out, but can you comment on the role of the labs with translation to clinicians?
It is cutting out a little bit for you too, John. Can I comment on the role of labs in? With
knowledge translation to clinicians.
Yeah, it's probably an area that we've underdone to date. It's an area to grow. I think it's about the conversation. So, for example, it's about the opportunities at the end of a study to sit back with a group of people and reflect on what those translational messages might be, and then to co-design with them as well the ways to achieve that and get that into practice. So I think there's an area that could be more advanced and thought about in detail. In our work, the translational side of things has come from our Living Labs participants working with the Agency for Clinical Innovation, for example, whereby they were putting together their co-design guide and capabilities document. And that document is to guide partnering with patients and working on co-design within the whole sector. So they came and worked with some of our Living Labs participants to work through the guides and have specific feedback on elements of that. So that we consider is obviously a knowledge exchange translation activity. It's getting fed through to clinicians through the local health networks and that model, but it's not been a direct interface in that regard, as an example.
Okay, so the next one's from Emma. What do you see as limits of co-design? And are there any particular products or services or circumstances where it might not be appropriate or effective to co-design with people with lived experience of mental health issues?
I reckon Emma could answer that. I think it's I think we're still seeing that, and we have to think about the just hang on one second. This is my daughter's now co-designing our session here. Just one moment. I've got to just finish my presentation. There we go. Sorry about that. Emma, the limits of co-design. Well, I think there are limits, and there should rightfully be some. I'm not sure that we've well articulated them yet. We haven't, I guess the systematic review point and question before helps to think that through a little bit. At which point are we starting to talk about a process that leads to a product or leads to an intervention or leads to an output to the process by which people are starting to shift into another space. And I think it's probably important that we map out all of those different pathways so that we don't fall into the trap of people undertaking work and being involved in different activities that may not necessarily be co-design as well. The other limits, I suppose, from the trial are whether or not you can see the health outcomes for people that we might presume are happening. And I think that's probably the other thing to think about going forward as well.
Okay, so Charlene says, hi Vicky, so thanks so much for your terrific presentation. Just wondering if you have many cultural and linguistic or diverse people or non-English speaking backgrounds.
We just had a new group invited to the Living Labs from our last trial, so they've grown, but typically not a large proportion, and again, another area to expand on. And I think also we have to think about those, you know, the different ways of engaging, the different mental health concepts that people might want to look at and refer to, and all of those things, all of the above. There's a lot of, you know, there's a lot of scope, there's a lot of work in this space, there's a lot going on, and this is one example. And, you know, what we have established was our commitment, one, to building a model where we could embed lived experience within the research continuum, and two, have a commitment to co-design within that. Three, take the Living Labs idea, which is the open innovation model, drawing on the Scandinavian traditions, and really to expand on that. But also, because we're situated within a medical faculty, to be able to then say, you know, we have a living lab and we are a living lab, and lots of our environments are living labs, and there's huge opportunity for people to be involved in those living labs and to have people at the heart of science and medicine as well as a result of that. So I might have gone off on a tangent then.
Thanks, Vicky. So Shakira says, would you happen to have an appropriate wording you use for inviting people to become part of a living lab? For instance, if I wanted to invite my study participants to be part of your living lab. Thanks.
Well, our living lab wording is purely that we are, if I just go to our Living Lab web page as well, which I probably could have put that up for you, if people haven't seen it. We invite people to take part, to be involved in our collaboration activities. So just pop here. Go. 1 second. Okay, so everyone can see that. So our wording is pretty consistent in whichever and wherever space we're working in. We would invite people to be a part of co-creating research, education, improvement and health policy, for example. We have a postcard that we send out to people that just has a generic line drawings approach on it. To join the Living Labs, it has some short wording about what the Living Labs might be and that you can get involved. And then it's an opt-out, opt-in process. And what we find over time is that over time, some people just want to stay connected because they get an update once or twice a year from the Collaborator Hub. They like to contribute to the email responses and give us feedback and information that way, but they may not ever want to come to an actual co-design session, that they like being a part of it. So our model has really worked on trying to use language and approaches that are about building a community, and building a community of people who have lived experience, who can contribute through the continuum in the different ways that they choose. Very flexible, very open in that regard. So a lot of the language is on some of those sites there too, Shakira, if you want to have a bit of a look at that as well.
So we have about 5 minutes left. We'll try to get through as many questions as we can. So David says, how do you decide on a good cross-section of people to fit into the co-design groups? And what tips do you have to support people to be confident to take part?
So the confidence and whatnot to take part, very, very, very important. And very much what we're building on is the fact that we've built a relationship with many people over time through the research study. So people will have come to trust us and our group through the work we've been undertaking. So I don't think we should discount that and ignore that the people have come through a process and a continuum to the co-design living labs. So they build trust in the research team, the people who've been calling them to remind them to complete a survey or undertaking interviews, all of those things. So that's one way that trust is facilitated. The second way of building confidence is also having support, by which our Living Labs coordinator invites people into a lab, provides all the information of how to get there, how to park, or all of those components when it's face-to-face. Similarly, if it's digital, we're going to use this platform, let's have a test run, all of those things. So it's about supporting those processes and building that knowledge of the use, confidence in use of various tools and techniques before we get into the face-to-face setting. The other way is that we have the labs running consecutively at different times during the year, so people build confidence by coming in and out of different labs. The cross-sectional question, our particular focus is on lived experience of mental health conditions, and our group generally fit the bill for that. So in terms of cross-section, we don't go into huge lengths in terms of saying, have we got the right balance of this age, this mix, so on and so forth, because often it's not needed at that point of co-design. We've got capability to do it if we need it, but it's often not needed. So yeah, and that also depends again on what the lab session's for. You know, if it's got some really particular needs, then we need to know those in advance to be able to identify the right fit group of people.
Okay, we might have just time for maybe 2 more questions. Joanne says, can you talk about the intersection of consumer involvement of health services design, and are there risks of developing a system that's not implementable, which could disfranchise consumers from further involvement in these activities?
You might have to repeat, sorry. Are you in section? I've got it. Well, I suppose there's a risk. There's always a risk of disenfranchisement in the sense of building hope within a community and then not seeing it delivered on the ground. So there's that. So we also spend a lot of time talking with people when we talk about our statements of participation and how we're going to work together. We also spend a lot of time with people explaining how research functions and operates, and how it might be that we are excited about contributing to this grant proposal, but there's no guarantees that it is going to be funded, for example. And we also talk a little bit more about timeframes to set up those clear expectations and not try to overpromise on what we're doing as well. So I guess a system that's not implementable, I'm not sure. I'm not sure exactly where that fits, you know, exactly where we could talk to with that. But I do think we have to have clear expectations and boundaries. And when we undertook the co-design trial, for example, and when we went to the co-design groups at the services, it was very much about saying, look, here's a range of things that we've all come up with. However, these 3 things are things we cannot change. So let's not spend all our time and effort co-designing something for them. Let's actually focus on the things that we can implement and put into practice. So implementation feasibility is always sort of in the background, I suppose.
Okay. Vicky, do you think you have time for one more question?
Yes.
Great. Okay. So are there any particular strategies you've used to build trust with those who are keen to be involved as co-designers?
Any particular strategy speaks a little bit more to the question that I answered before about the building trust, having relationships, pre-existing relationships, a point of contact that people know. People know us when they come into the living labs. They've been to living labs before. They know the facilitators. We generally have the 2 researcher models, so there'll be myself and another person within the team co-facilitating, so we're known. Yeah, I suppose it is very much a relationally driven model. That would be a short answer to that one.
Okay, so there are about four more questions on the chat room. I understand it's 1 o'clock and some people need to go. Vicky, how would you like to proceed? I'm happy to send the questions to you if you're happy to answer them on time, or do you want to keep going?
How quick are they? Is that... I think I can see one here about the cultural diversity. Look, we've had similar questions around people attending a hospital or attending a university institution, but, you know, can be similar for people with mental health experiences. So I suppose that is where we have had the option of people taking part virtually who feel more comfortable to undertake those activities. It doesn't mean it fits for everyone, but that has been another pathway that people have engaged with who may not come to the face-to-face sessions for whatever reasons that might be, whether it's the, you know, experience of going to an institution, all of those things that are very valid and important. The other thing is that we have been resourcing our co-design living labs through our research projects. So we don't have a particular stream of funding for that. We have a commitment to it whereby we make it happen. So I think if you were to suggest that there were other funding sources and other ways of resourcing, then you would be taking it to community as well and finding the place where it best fits for the people who want to engage. So that would be my comment to the one about cultural diversity there in particular. And the only reason, as I said, that we don't necessarily do things out in the community at scale is a resource issue. We just don't have the funds to go out and do it, and the space, purpose-built kind of spaces that we need for it.
Okay, there's
I'm
another
glad,
question
I've
on
had support from the group about responding to my daughter. She's likely to be cross after, but I'll let you know how it goes.
Vicky, there's one more question on whether you think that participatory approaches are becoming a minimum requirement in healthcare services.
As in a minimum standard? Is that where that one's coming from? Like as in it should be required?
Yeah.
Yeah, look, I think it's from a policy perspective, that's certainly a requirement from a research and policy perspective. The extent to which it might well be happening in practice in a truly committed way is probably variable and has been for, you know, plenty of years before now, before the zeitgeist was upon us. But, you know, I think that's also the other part to take into account, that we are talking about a phenomenon that has many intersecting parts across the healthcare setting, that also has a confluence of the socio-cultural patterns and ways that we're participating in healthcare currently as well.
Okay, Kathleen has a question about to what extent could participants set their research agenda for what priority problems and research areas? We'll go ahead.
Yeah, 100%. To what extent, you know, again, that has been one of our desires, is to have a more formalised approach whereby we could be providing some of the potential priorities and having ways that people can engage with that and shape that and contribute to it. So I think there's huge scope for that. We certainly undertake it in the sense of trying to, well, we're all driven by the constraint that the funding that's announced has a certain focus, but within that constraint and parameter, we're always trying to go back to our groups in particular. As I said, you know, we've got over 1,000 people in the registry. Not all of that group are on email, for example. Like, so there's some are on email, some are on SMS, and then there's a very small proportion in there, probably about 50 odd people, I think, at our last count, who are only by letter. They're probably our older cohort who come out of our 10-year longitudinal study, but that's their only way of communicating. So I think the setting of priorities is 100% of potential. It should be happening. We do it within the constraints and opportunities that we have at hand, but we also need to think, how can we facilitate that across the board when you look at a group like this with a mix of different modes of communicating that aren't always going to fit, you know, put up a web page, do some voting, and people tap in. They're not necessarily going to reach all of the population.
Okay, I think we have one more question from Greg. Have you looked at the use of AI technologies in this work? A couple of your University of Melbourne participants attended a workshop on ethical challenges in the use of AI technologies in the home of people with intellectual disabilities, which was very informative.
I didn't hear, sorry, which I've got back
Have
up.
Have you looked at the use of AI technologies in this work?
No, not extensively. Our last project which used the Living Labs participants in the first instance before we went more broadly, was completing some what we call story stems online, looking at the ethics of health data use. So before we went broadly out to the public with that particular project, we also then floated it through the Living Labs group to get feedback on, did these story stems make sense? What wording would you change or not change, and so on and so forth. But in terms of AI technologies in particular, we haven't gone down that path. If you remember back to my early slides, you know, this is a program of work in integrated mental health. So we, in our particular program right now, we haven't expanded into AI technology. So that would be the only reason that we haven't had those conversations, but just to remind that most of our work is anchored on all of the studies that we've been undertaking there in our program.
So just to explain that, the challenge we faced in the disability sector was AI companies claiming that by simply monitoring everybody, they'd be able to draw out lessons that were of value using AI. And we did an ethical review of that and determined that people should not be monitored by AI on the off chance that what they do will generate some interesting data. Yeah. The benefit to the individual needs to be closely connected to any degree of AI monitoring of the individual.
Yep. Yeah, and I'd support that, and that's probably the feedback you would get from our similar participants. Thanks, Greg, for explaining the context. Okay. Yeah.
Well, thank you, Vicky. Thanks for your wonderful presentation, and thank you for your time. I hope your daughter isn't too cross.
Thank you all. This has been great. I'm glad to connect via Twitter as other platforms, and I should also put up another platform just before we go, Dawn.
Yep.
For those interested who would like to start to connect further, that we do have now a space at the university level. I'll just stop. Whereby we can start to build this agenda further. Oop. And that's at the Participation Nexus. So you can come here to start thinking about the ways in which we might be able to build a participation agenda through the university channels. A nexus, of course, is playing on the concept of a series of interconnection. And we very much recognise that there are a variety of ways that people undertake participation, and some excellent models across the board. I've shared our model and some of the things that we're doing. There are many. So this space here is to become a point of intersection whereby people with lived experience, patients, community, industry can come together and use their experience to change things for the future. Did I share that? Yes. Wasn't sure if I shared the page.
Yeah, you have. Thanks, Vicky.
All right.
So Sulam has asked whether she can have a copy of the slides in reference to the nature issue.
Yeah.
Thanks. All right, everyone. So our next online seminar on Thursday, 7th of May at the same time, 12 to 1, we'll have Professor Karen Bispo, who will be presenting on using real-world evidence to investigate clinical research questions. So we'll love it if you can join us again.
Okay, just before we go, Dawn,